Well, good. Well, thank you all so much for joining us today. As you know, this is the training webinar for the demonstration of the Health Literacy Universal Precautions Toolkit. I am Angela Brega. I'm what's called the task order leader for the project. I'm basically the scientific lead for the project. I think it's helpful just to give you a little bit of a sense of my background so you know where I'm coming from. I'm an associate professor at the University of Colorado, both in the School of Medicine and in the School of Public Health. And most of my work revolves around trying to improve diabetes and cardiovascular outcomes among American Indians and Alaska Natives. But over the past several years, I've come to be very interested in trying to understand how health literacy impacts people's ability to manage their diabetes in particular. And so this project is one that I was very excited about because it gives us an opportunity to take some of the things we know about how to communicate more effectively with folks who may have a hard time understanding health information and actually implement it in the real world. And in the process, help providers know how to communicate better, but also hopefully help patients understand their health better and be able to manage their health better. I'm delighted to be a part of the project, and I'm so pleased to have a number of practices who will be working with us who seem to be really excited about it and commit to the idea of doing some quality improvement work around health-related issues. So thank you all so much for being here today. Just to give you a sense of what we'd like to cover today, I'll start with basically an introduction and a little bit of information about staffing of the project. I'll also talk a little bit about health literacy itself so that we all start out with this basic understanding of what it is we mean when we talk about health literacy. In addition, I'll talk about the Health Literacy Universal Precautions Toolkit itself. I'll mostly spend our time today talking about the demonstration project itself and what the activities that are involved in that and the times that go along with those. So let me take a few minutes here to introduce you to a member of our project team who will be someone you have contact with and will be in the future as well. I'll let her introduce herself, but this is Julie Bernard.
Also, I received email invites from me this morning for the webinar, and thank you for joining us. I'm thrilled to be a member of the team. As you notice, my first full name is Juliana, so don't let that throw you as far as my email address. But I love going by Julie, so that's what I go by normally. But I have been with the Children's Outcomes Research Program doing primarily immunization delivery work in the community for 6 years now, and then prior to that at National Jewish Health as an epidemiologist, 12 years actually. So I'm going to be a member of this team and really look forward to working with you on this project.
So Julie is our project manager, and we anticipate that she will develop sort of a co-project management role with a new team member who's going to be joining us from the American Academy of Family Physicians. And you may all recognize the name Liz Horsley. She has been a key member of our project team for a number of years now, but unfortunately has left the American Academy of Family Physicians. So we will be bringing on a new staff member in the next few weeks. We'll introduce him to you all when we have him on board and to go. In the meantime, Liz is not a primary contact for you all anymore, but you can get in touch with Julia and I if you have questions or anything in the meantime. So I think that's everything about the research staff. We have several other research staff members as well who are not able to join us here today, but they'll be folks you'll meet over the course of the project. Talk a little bit about health literacy and what it is and what we know about it. Typically, we define health literacy as the capacity to obtain, process, and understand basic health information and services to make appropriate health decisions. Now, I think of the sort of shortened version of this, that health literacy is really the ability of someone to understand and use health information. we think of there being a few different kinds of skills that make up somebody's health literacy. So what are the things people need to be able to do in order to really be health literate? These are the three things that we think of as the main components of health literacy. First of all, we think about something called print literacy, which refers to people's ability to read and write in the context of health. So to be able to read those discharge instructions or my appointment slips. I need to fill out some pre-exam paperwork when I come to your office for my annual visit. There are a number of ways in which reading and writing become important in the management of one's health. We think a lot about oral literacy, and I imagine you all run into this kind of thing every day. It's very important that people be able to speak and to understand speech related to health. So people need to come in and be able to explain to you what their symptoms are, what their concerns and questions are, and in turn they need to be able to understand what you tell them about their diagnosis or the treatment plan or how they should take their medications. So literacy is a really important part of people's ability to manage their health, and something I imagine you all run into every day. There's another component of health literacy that doesn't receive as much attention, but we call it numeracy, and it refers to people's ability to understand and use numbers. If you think about the things we ask patients to do every day to take care of their health, a lot of those tasks involve numbers. So as I mentioned, I do work in diabetes, and almost everything we ask patients to do involve numbers in some way. They understand what those numbers mean on their glucose meters and make appropriate decisions based on them. They may need to count calories and carbohydrates, take medications at the right time and the right dose, and may even need to do very complex things like adjusting insulin doses. So not only for diabetes, but in many parts of healthcare, patients need to understand numbers because it's important in their ability to manage their health. Now, what do we know about how common it is for people to have limited health literacy skills? Well, we only have one really good source of information to help us understand this, and it is the National Assessment of Adult Literacy. This is a national literacy assessment that happens every 10 years in the United States, but in 2003 they added a health literacy component, and so it is the only randomized national large sample to which we can look to understand what literacy skills of adults in the United States are. What we find from the NAHL is that 36% of adults in the United States have significant limitations in their health literacy skills. You extrapolate that out to the population, that represents 77 million U.S. adults. And folks that were categorized as having limited health literacy skills would have doing some very basic things, following directions on a medication label, or looking at a childhood immunization schedule and appropriate decisions about when their child needs to be immunized with which vaccine. Those are some basic tasks that we all run into as we go through our own healthcare experience, and yet these are things that a third of the U.S. population, the adult population, would struggle to accomplish. Now, one of the things that the NAHL and quite a bit of other literature tells us is that there's a very strong link between limited health literacy skills and demographic characteristics. So folks who have higher levels of income and education tend to have higher health literacy skills. Also, certain racial and ethnic groups are more likely to have limited health literacy. So, for example, African Americans, American Indians, Alaska Natives, and Latino populations all are more likely to have limited health literacy skills. It's important to know is that although health literacy, the prevalence of limited health literacy stays about the same throughout the life course, for patients of the age of of 65 or older, the prevalence of limited health literacy skills is much greater, so close to 70%. We're in a practice where you see a lot of older folks. This is something to really be aware of. A very important finding in the NAHL, though, is that although it's clear that there are groups that are likely to be at risk of limited health literacy skills, there are really no groups that are immune to limited health literacy. So if you look among very high-income people, very highly educated people, you will see a significant subset who have a hard time understanding health information. So the implications of limited health literacy. Well, as you may know, there's a very large and quick growing literature that looks at the relationship between health literacy and all kinds of other health outcomes. What I'll present here today are the findings from a systematic review. And so these are findings that are very consistent in literature about which we feel very confident. One of the findings that is very consistent is that folks with limited health literacy skills have limitations in their knowledge about disease or health. So, for example, in work I have done, I've seen that folks with limited health literacy skills have more limited diabetes knowledge, cardiovascular knowledge, heart attack and stroke knowledge. All kinds of different health and disease knowledge measures are linked to limited health literacy. What we see is that folks with limited health literacy skills are more likely to use inpatient and emergency care. That's even true when you look at populations that have the same access to care. We know that medication adherence is highly related to health literacy. So folks with limited health literacy skills are less likely to be able to read their medication labels, to have the actual skills to take their medicines correctly, and therefore are unlikely to adhere to medications as well as folks with with stronger health literacy skills. Understandably, folks with limited health literacy have trouble with those written labels and other sorts of written instructions or written health information that you might give them. And we see that limitations in health literacy are associated with worse health status and with higher mortality rates. All the literature shows us that there are substantial limitations in health literacy across the U.S. population, and that limitations in health literacy have significant implications for health. So it's important for us to think about what do we do about this problem. How can we address health literacy and help patients with limited health literacy skills to avoid some of those negative outcomes that we see? As I defined health literacy as being a set of skills that a patient has, when we think of how to intervene with regard to health literacy, we start to think of it as more of a balance between skills that a patient brings to the table and the demands that we place on them. So my health literacy skills may be perfectly adequate in a situation where my provider is communicating with me words that I understand, is only communicating a few important points, and because of what I have to go home and do to take care of myself are fairly limited. Other situations where my health literacy skills are woefully inadequate to the information that is being provided and to the self-care regimen I need to follow. So as we think about how to address problems related to health literacy, what we want to do is reduce the demands that we place on patients. Typically, we do that by trying to improve our verbal communication with patients, our communication with patients, and to provide them with other sorts of supports that can help them to do a better job of managing their own care. For a while in the literature, there was a bit of a debate about whether we should start screening all patients for health literacy limitations. The idea being that if we knew who had understanding health information, we could use the way we communicate with those specific patients to support them better. But we have come instead the conclusion that really we need to use sort of a universal precautions approach to health literacy. And by that, we need to structure the care we provide in a way that reduces the demands that we place on all of our patients, not just those who we know to have limited health literacy. And there are a number of reasons that using a universal precautions approach really makes a lot of sense. One of the things we like to say is that you can't tell by looking who is going to have a hard time understanding health information. Mentioned about the NAHL findings, it's clear that there are significant limitations in every demographic group. So look, for example, at the group of people who have at least some college education, a third of them have limited health literacy skills. I also see that providers very commonly overestimate patients' health literacy skills. So through your day and you talk to patients, there may be some that you recognize are having a hard time understanding, and there are others that will escape your notice. There's lots of studies in the literature that suggest that's the case. Now, reasons that it's very hard for providers to identify patients with limited health literacy is that they will often not give you any clues that they're having trouble understanding. So with limited health literacy skills are less likely to ask you questions. They're likely to ask you to slow down or repeat yourself. And in some ways, patients with literacy are likely to very carefully pretend that they aren't having trouble. They will tell you that they didn't bring their glasses and that's why they can't fill out that form you gave them, or tell you that they understand if you ask if they understand. So they are often not likely to fess up to you that they're struggling with the information they're receiving. Another thing to remember about health literacy is that it can be dynamic. So as I mentioned earlier, health literacy might be adequate in some situations, but so in others where the demands are greater. In addition, literacy may be diminished in situations where a patient is under a lot of stress or is experiencing a acute health problem, and they may feel overwhelmed by that. Their ability to understand health information and make decisions appropriately based on it may really be diminished in that sort of a situation. Another important point is that there is no one who wouldn't benefit from clear communication. So even among folks with real strong health literacy skills, having their providers communicate with them in a way that would be appropriate for those with limited skills is a problem. It actually is beneficial for them as well. Toolkit itself. The tool was commissioned by the Agency for Healthcare Research and Quality, AHRQ. That's a federal agency that has shown a lot of interest and commitment in issues related to health literacy. They funded development of the toolkit, which was really done by a well-known health literacy research group at the University of North Carolina, Chapel Hill. The objective in developing the toolkit was really to provide primary care practices with a resource they could use to identify areas where they could improve with regard to health literacy related issues, and also to guide them step by step in how they can go about making changes in their practice that would improve what we do as the health literacy environment in their practice. This tool is really based on a quality improvement framework. So the expectation is really that you will assess how you're doing right now with regard to health literacy related issues, and will identify areas for improvement based on that assessment. And then you'll go through sort of a cycle of implementing some changes and see how those are working, and maybe tweaking how you want to implement some changes, and going a cycle of quality improvement. Toolkit, of course, as the name would imply, really focuses on using a universal precautions approach to health literacy. So focusing on changing new practice for all patients, not just those with limited skills. Now, they all have these links already, I wanted to go ahead and provide you with the 2 links where you can find the toolkit. And I wanted to mention another thing, that these groups are actually actively going through their materials to make sure that all of the links still work. And so I know they've gotten through tools 1 and 2, but that they may not have gotten all the way through the full toolkit at this point. So as you go back to the toolkit, it's always probably a valuable thing for you to actually go back to these links and pull down the most recent version you can, so you've got the version that has the updated links in it. Contents, you might already know, focus on 20 different tools related to health literacy. Now, there are 3 tools that are really designed to just get you started with health literacy quality improvement work. And I'll talk about some of those tools in a minute. There are 4 domains into which the remaining 17 tools fall. There are a set of tools that focus on improving spoken communication with your patients. There's also a set of tools that focuses on improving written communication. The 3rd domain really gets at trying to improve self-management skills of your patients and trying to empower them and really bring them into the healthcare process so that they can kind of feel empowered and take charge of their own care. The domain focuses on trying to improve support systems for patients. So, for example, there are tools related to trying to link patients up with resources in the community that could be supportive for them. For example, diabetes education classes or weight loss classes, or even English as a second language classes and other sorts of educational resources that might be supportive for them. This is very nicely structured in that each tool really follows the same predictable kind of format. The tool starts with an overview and a discussion of why tasks in this particular tool are important. And then the toolkit will provide you with a set of action items that you can implement in your own practices to improve health literacy-related practice. Again, because this toolkit is really designed around a quality improvement framework, each tool will also provide you with ideas about how you can track your progress with a given tool. So as I make these suggested changes, how I know that they're having the impact that I'd like them to have. The tool actually gives you some ideas about how you might track your progress. Each tool will provide you with a list of resources that will provide you with additional information relevant to that tool. About the demonstration project itself, activities and tasks and timelines involved in this project. As you may know, the project is being conducted jointly by the University of Colorado and American Academy of Family Physicians National Research Network. And we are funded by AHRQ, that's the same group that funded development of the toolkit. And you may know we are working with 12 primary care practices around the country to implement the toolkit. We have primary family practices, but also are working with some internal medicine practices, some community health clinics, and some academic residency programs. So we have a nice, diverse set of folks that are really interested and committed doing this kind of work. Very excited about that. The objectives of the project are really twofold. First, we want to examine the impact of toolkit implementation. So see what happens when you take this toolkit and implement it in your practices. Be able to see that you are able to put in place new procedures that be supportive of patients of all literacy levels. Can we see that patient materials have been revised, or that there's actual evidence that patient-provider communication has been enhanced as a result of toolkit implementation? The kinds of things we'll want to look at as we go through this project. an important goal for us is to identify ways in which the toolkit can be improved. As you are using the toolkit, you may identify places where an additional resource may be valuable or where clarification could be useful. Heck, you may even find that there's a whole new tool that you would recommend be included in the toolkit. So we will, as a result of this project, be data that you collect and also talking with you the experience of implementing the toolkit, any suggestions you have about how we can make it better. At the conclusion of the project, we will in fact be producing a revised version of the toolkit based on the kinds of feedback that we receive from you. So this is a second but important goal for us. Next several slides, I'll talk about the main project activities that are part of this demonstration. The first of those, of course, being toolkit implementation, so we'll spend a bit of time talking about that. We'll also talk about data collection activities involved in being part of the project, and site visits. Later on, I'll show you a timeline that sort of pulls all of those activities together in chronological order, and so hopefully that will give you a good big picture view of what our activities are and when we expect them to be happening. Also, a little later on, talk a little bit about technical assistance and also about IRB-related issues. Let's talk about toolkit implementation. All of the practices that are involved in the demonstration will implement 4 tools over the course of about a 6-month implementation period. 2 mandatory tools that every participating practice will implement. In a minute, but I'll just give you a little teaser here about them. Tool 1 is a tool that will help you to form the health literacy team that will actually implement the toolkit in your practices. It will help you to assess your practice, to get a sense of where your current strengths and weaknesses may be with regard to health literacy-related issues. In addition to these 2 mandatory tools, tools 1 and 2, all practices will also implement 2 additional tools. And we refer to these as the practice-specific tools, because these are tools that you will identify as being particularly relevant to your practice. You will identify them that way as a result of the assessment that you do as part of implementing Tool 2. So that Tool 2 will help you to identify areas of improvement in your practice and use that information to identify the tools that are most relevant to your practice that you might select as your 2 practice-specific tools. Now, I mentioned before, but we would like to ensure that we cover as many tools as we can as part of this demonstration, so that we learn as much about how the tool works and how we might improve it as we can. And so we would like to have you remain a bit flexible and work with us to identify those 2 practice-specific tools. So what we'd like to have you do is tell us, highest priority tools for you. And then we can work with you to nail down which are the 2 that you'll really implement in your practices. Practice-specific tools that we'd like to have you choose from are listed on this screen. The research team has actually gone through the toolkit and identified a set of tools that we think of as being the highest priority tools in the toolkit. And this is the list of the highest priority tools. I'd like for practices to select their practice-specific tools from this list of tools right here on this screen. Some other tools in the toolkit that we did not identify as of being particularly high priority for this project. They're certainly important tools, but they haven't been selected to be a main focus of our demonstration. I see the list of these tools on this screen, and we refer to them as optional tools. Tools here that you are particularly interested in implementing, you are welcome welcome to do that. However, we would not count tools among your 4 required tools. So just to be very clear, I'd like to have you select your 2 practice-specific tools from the list of practice-specific tools on this screen here. And if you're interested in some of the optional tools, you can implement those in addition. Talk about implementing tools 1 and 2 today, because this is work that we'd like to have you get started on right away. One is the tool that will step you through the process of forming your health literacy team. It discusses the importance of having a very strong team and having the right people on the team. So it will give you some guidance on what the membership should be, people who really should be in the room, how big should this team be to still be manageable, and how often the team meet in order to effectively implement the toolkit. In addition, this tool provides resources for how to train the members of your team. So identify folks to be part of your team who are not experts in health literacy, and some resources identified in this tool that will help them really get up to speed. Now, one of the things I'd like to mention is that I know some practices really have a pretty good idea at this point of who they'd like to be on their team. And what I'd like to ask you to do is really sit down with this tool and read through the recommendations that it makes, and ensure that the team you've selected really fits with the guidance provided there. Think about whether there are any changes you might make based on what is made available to you in Tool 1. The second tool that we'd like you to get started on is Tool 2, which allows you to assess your practice. Now, as part of this tool, you will ask members of your staff to implement or to answer the questions that we refer to as the health literacy assessment questions. Questions that are actually included in the toolkit itself, so they're a resource available to you through the toolkit, and they have been designed specifically to help you assess health literacy-related aspects of your practice. So, implementing Tool 2, you will have several members of your staff complete these questions, and you all will sit down together and walk through folks' responses to those questions to identify areas where you may be doing a good job and areas where you maybe could make some improvements. One of the great things about the health literacy assessment questions that not only do you have the opportunity to see where some areas for improvement may be, but each question will identify for you what tool will help you do that. So it's a very nice resource for you to use to find some areas of improvement in your practice. So it's doing a process that will help you to really identify what are the tools that are likely to be the most relevant to you to select as your practice-specific tools. Now, I'd like to have you implement tools 1 and 2 over the next month. We hope that a month from today, you would submit to us a form we call the implementation tracking form, which is a very brief form that will just tell us a little bit about implementation of tools 1 and 2, and will also identify for us the tools that are highest priority from our perspective to implement in your practices. Basically, we will be asking you to identify your top 4 tools in priority. Glad you could be here. So with regard to these health literacy assessment questions, you'll have staff complete these as part of implementation of Tool 2 and complete them again at post-implementation. And staff will actually just fill out a hard copy of this form, give it to the project coordinator who will data enter those responses into an online data entry form that we will provide to you. Data collection form that will be used at both pre- and post-implementation is the staff survey. This is a survey that really allows staff to tell us a little bit about their experience with health literacy and their use of recommended strategies for communicating effectively with folks with limited health literacy skills. Post-implementation, it'll allow folks to tell us a little bit about what they perceive to be the success of implementing the toolkit. What we'd like to have you do with the staff survey is as many of your providers and staff complete the survey as possible. You know, we'd like to see every single employee in your practice complete this form, in part because you get a really diverse set of responses from the different folks you ask to complete these items. And so, again, we'd like to have as many people complete the staff survey as possible, both providers and other kinds of staff. You can't get every single person to complete it, to make sure you have a diverse array of staff completing it. So you want some of your clinical providers completing it, as well as your front office staff, and if you have a pharmacist, if you have other kinds of disciplines and specialties in your group, as many folks and as a group of folks complete this survey as possible. Now, this is a survey that will be completed online, so we will send you a link to the survey that you can share with your employees, and just go to that link and fill out the survey. Now, the final tool that will be used for data collection at pre- and post-implementation is the Health Literacy Team Leader Survey. And this is a survey that literally will only be completed by one person in your practice as the Health Literacy Team Leader, or the person who really is running your health literacy team. And this is a survey that will really get at issues related to implementation and changes that have been made in the practice as a result of implementation. Will also be completed online. We'll send a link to the health literacy team leader, and he or she can just go to that link and complete the survey online. Now, again, we will send you links to all of these surveys and data collection forms that will be completed online. We'll provide that to you at the very latest in May, and maybe earlier this month, actually. One thing I'll say is that all of the online data collection forms that we'll be providing you with are forms that you can complete, you know, parts of, and then save, and then go back and finish them later if you need to. So people are busy and get interrupted by various things throughout the course of your day. So we wanted to make sure that you're able to stop a survey if you need to, and then come back to it later. And we'll explain when we send you documentation later about how you would go about doing that. Form that I referred to earlier called the implementation tracking form. And this is a very brief form that your project coordinator will fill out. Have you complete at several different times during the course of the project. And this is really just intended to capture sort of a snapshot of where you are with implementation of your tools at any given time. So I mentioned that we'll have you submit the implementation tracking form for the first time a month from today. And at that time, you'll be telling us about your implementation of tools 1, 2, and what your priority tools are for your practice-specific tools. It should take you just minutes to complete. It's very quick and easy, but gives us a sense of what are and what the timeline was for implementing those tools. We will have you complete the implementation tracking form again several times throughout the project to tell us about your implementation of your practice-specific tools. Specifically, we'll have you complete this form 2 into the implementation period, and again 1 month, 2 months, and 4 months into the implementation period. And you'll just be telling us a little bit about where you are with progress on those 2 different tools that you'll be implementing, those practice-specific tools. And those will be completed online, and we will send you a link to those forms at the time that it becomes relevant for you to fill them out. Now, what I mentioned about data collection is that there are 2 specific tools that require some additional data collection for practices that use those tools. One of those tools is Tool 8, which guides practices in conducting brown bag medication reviews with their patients. Now, I really encourage practices to consider this tool because we know from a very small pilot test that was done as part of development of the toolkit that practices found this tool to be very eye-opening, and they found a lot of problems in their patients' medication regimens when they sat down with them to go over medications with their patients. So I think it's a very valuable tool. Practices that are interested in using this tool will collect a little bit of additional data at both the pre-implementation and post-implementation time periods. Typically what we would like to have practices do is do a medication review with 20 patients at the pre-implementation time period and 20 at the post-implementation time period. At the conclusion of those reviews, the person who actually does the medication review will complete a hard copy of the medication review form. This is, I think, a 2-page form that is really geared toward allowing you to tell us what sort of problems you saw when you reviewed medications with this patient. So, for example, did you find that some medications were expired, or that patients were taking the wrong dose, or that you needed to change the one medication to another? We just want to have you fill out this form to give us a sense of what kinds of issues you found as you did those medication reviews. As the provider completing the review will fill out this medication review form, and then the project coordinator for your site can enter the data into our online data entry form. All of those data will be de-identified, so we will never know anything about who the patients are that you reviewed. You're welcome to put the copy of this form into your medical records as information for yourselves for later. Now, the other tool that requires some additional data collection is Tool 17, and this is a tool that guides practices in getting feedback from patients about the literacy environment in the practice. This is a tool that we consider to be very important because those patients can really tell us a lot about how we communicate and whether they're understanding the information and the written information they're receiving. And so we will ask 6 practices to implement this tool because we really think it's so important. And there is a little bit of additional data collection that would go along with implementing Tool 17. First of all, there is a patient survey. So all 6 practices that we ask to implement Tool 17 will implement the patient survey. And part of that, they will collect patient survey data for 50 patients at pre-implementation and 50 patients at post-implementation. Now, we need to get written informed consent from patients to do this survey. As part of our IRB approval, we have received a waiver of consent for this process. And the other important thing to know is that patients will complete the survey using a touchscreen tablet. So there will be no data entry or anything on your end. We're very excited about the touchscreen tablets because not only do they allow the patient to see the questions in written form, but the questions are also narrated. And so people who don't have great reading skills will be able to listen to the questions narrated and answer them and be able to provide their own feedback as part of this process. So for practices that will be implementing Tool 17 and collecting patient survey data, we'll provide you with some additional information about how that process will go in May before you get started. Now, for 2 of the practices that implement Tool 17, we will also arrange to have an additional survey collected for them. And that is a survey that includes items from the Consumer Assessment of Healthcare Providers and Systems. That's called the CAPS. you know, the CAPS has a whole set of items specifically related to health literacy. And so for 2 practices, we will arrange for a survey vendor to collect CAPS data for 3 patients at pre-implementation and 3 post-implementation. And you won't have to do any patient consent process with regard to this. The survey will be collecting patients directly. They'll send the survey out by mail and then follow up by phone. That survey completed. This will be completed in both Spanish and English, which is exciting for us because it'll give us an opportunity to have your Spanish-speaking patients provided as well. Now, so in terms of the CAPS survey, the practice activities go along with that that you would be involved with are really 2 things. You would need to develop a business associate agreement with the vendor. That's legitimate for you to provide patient contact information to the vendor for this purpose. And then you'd also need to provide contact information to the vendor for patients who have been seen in the past 60 days. Do that both at pre-implementation and post-implementation. These are really the 2 activities that the practice itself would be involved in as part of the collection of these CAPS data. I also want to talk about site visits. We will be visiting each practice 2 times during the course of the project, one time at the pre-implementation time period and one time at the post-implementation time period. Each of those visits will be a day in length, and typically we will have members of our research team there to visit with you. The folks we would like to be able to talk with during the time that we're there are your project director, your project coordinator, the leader of your health literacy team, as at least one other member of the health literacy team. And at the post-implementation site visit, we'd like to have the opportunity to meet with 1 or 2 additional staff members who have not been a part of implementing the toolkit. Receiving emails from Julie recently about scheduling these site visits, and we'd like to do that as quickly as we can so that you can get everybody's schedules arranged and so that we can make plane reservations and hotel reservations. So if you've not had a chance to respond to Julie, the times that we have proposed to come visit you for the pre-implementation site visit, I would encourage you to get in touch with her as soon as you can so you can get that all nailed down. The agenda for those site visits includes the things that we have listed on this screen here. It's an opportunity for us to talk with you about the plans that you have for implementation of your project-specific tools, progress you may have made with implementation already, challenges that you may have run into. It'll give us a chance also to talk about what steps, whether that be with regard to implementation or data collection, or setting the project up when we come at the second site visit. We will also talk with you about data collection procedures. You may just be starting or have gotten partway through your data collection at that point, and it'll be a chance for us to check in and make sure things are well, that you don't have any questions for us that weren't already addressed. In addition, the project team, so the site visitors themselves, will spend a little bit of time observing practice environment. Primarily, we will be observing what's going on in the waiting room. We'll look at things like signage. So is it easy to find your way around the office based on the signs that are available? I also like to observe the check-in and check-out process with 5 different patients, to be, quite observers and see how those interactions go. At the time that we are at your sites, we would like to collect copies of the written materials that you share with patients. So if there are particular educational materials that you provide to patients, we'd like to get copies of those. We'd like to get copies of sample test result letters that you might send, or appointment reminders, information about how to access the patient portal, all of those kind of things. Consent forms, HIPAA forms, privacy policies, those kinds of documents that you might provide to patients, we'd like to collect copies of. And our goal there is really to be able to come home and sit down with those materials and get a sense of how easy or difficult they are to read. In addition, at both site visits, we'd like to have the chance to interview certain members of your staff. So at both the pre-implementation and post-implementation site visits, we'd like to do a probably hour-length interview with your health literacy team leader and with another member of your health literacy team. At implementation, we'd like the chance to do a brief interview with one or two staff members who have not been part of the implementation process. A timeline that shows all of these tasks in chronological order. And so here is that timeline, and I'll talk through it. So in April, of course, we're doing training webinars and trying to get things scheduled in terms of site visits and that sort of thing. If from the moment you get off this phone call until a month from today, we'd like to have you working on implementing tools 1 and 2, with the goal of having you submit the implementation tracking form to us a month today. And again, that form will identify for us what your priorities are in terms of the practice-specific tools that you'd like to implement. For any of you who have IRBs that oversee your sites, won't want you to send us...
Denise Miko, sorry we got disconnected.
Okay, well, welcome back. For those of you who have IRBs of your own, we won't want to have you send us any kind of data until you have received IRB approval. Now, June is when we expect pre-implementation data collection to take place, and June is also when we'll start to come visit you. Probably between the various parts of June through the middle of July is when we'll be doing those site visits. July to December is when we expect folks to be implementing their 2 practice-specific tools, and then January of 2014 is when we anticipate post-implementation data collection to happen. Also when we will come see you again for our second site visits, and because there are quite a few of them to do, it'll probably take us into the early to part of February to get those site visits completed. So hopefully this timeline here is a way of seeing all of those tasks we've just talked about, but seeing in chronological order with some timelines attached. Now, I do want to talk briefly about technical assistance. We'll be providing technical assistance as part of the project, but it may be more limited than what you have received on other projects you've been involved in. We're doing that for a very specific reason. Now, this toolkit, as you know, is out there online, and it's meant to be a standalone resource that any practice who wants to can download it and use it. We really want to assess implementation of the toolkit under standard conditions. We want to see whether this is provided there you to make important changes in your practice that are supportive of patients with both limited and stronger levels of health literacy. So we want to learn about the barriers that you face as you implement these tools and what sorts of facilitators help you jump over the hurdles that you encounter. We also want to understand what kind of technical assistance practically need as they implement these tools. Part of our goal is to develop a resource that will demonstrate the kinds of technical assistance needed. And so we want to automatically provide you with all of that technical assistance, but want to see what it is you really need from us, so that we can make sure that in the future practices are aware of that and facilitators are aware of that. The planned approach to technical assistance is that during our pre-implementation site visits, we'll be talking with you about your 2 additional practice-specific tools. We'll have a chance then to really talk about your plans for implementation, kinds of barriers you anticipate, and start to talk through with you how you might tackle some of those problems and other aspects of implementation. We are having 4 check-in phone calls with you during the implementation period. Those will happen 2 weeks and then 1, 2, and 4 months into the implementation period. Now that timeline will sound very familiar. That's the same timeline on which we'd like to have you update your implementation tracking forms. So you will ask you to do that prior to sitting down and talking with you briefly about how things are going. And so that'll be a chance for us to identify barriers, technical assistance needs, and provide you with some guidance on how you might approach some of the things you're running into. We want to assure you that the research team is always available here to answer your questions. If you run into issues, you need to wait for a site visit or for a check-in call, you're going to contact us, call us, or email us with any questions you have so that we can help you think through some of the implementation questions you run into. Now, we'll talk a bit about IRB-related considerations. You all know that the project has received approval from the American Academy of Family Physicians IRB. So we are covered by that IRB for this work. And for those of you who do not have your own IRBs, you will be covered by the AAFP IRB. Several participating practices that do have their own IRBs. For those, as you already know, the project team will be working closely with you to get the IRB protocols pulled together and submitted that are needed to get approval from your IRBs. Now, I think at this point we're making pretty good progress with most or all of the folks that we're working with, but I would just want to say that if we run into a situation where IRB is really taking a long time to review, or we're getting to the point where we don't think we're going to get approval in time for a practice to have the time they need to implement these tools and do the collection, it may be necessary for us to select an alternate practice to bring on board. I hope that doesn't happen, and we're working very hard to make sure it doesn't. We just want to make sure folks are aware of that in case it comes up. Again, just wanted to remind you that if you do have your IRB, we won't want to have you submit any data to us until you have IRB approval. Now, I just thought I'd run over a couple of screens here of the next steps, both from the practice perspective and research team perspective. This is just sort of reminding us, refreshing our memories about what are the tasks coming right away here. The next month, we'd like to have you all implement tools 1 and 2. In a month from today, have you submit to us the implementation tracking form that identifies your priority tools. That allows us then to start working with you to identify what the tools that you will implement will be. In June is when you will begin completing collection, and in June or early July is when we will come to visit you. Now, for the research team, our ongoing to-do list is to complete training webinars. We do have one more next week for any staff that you have not had to be able to attend, so please let us know if there's other folks that may want to attend next week. We also are actively trying to schedule site visits and get those site visits nailed down in the next week or so that it can begin getting on their calendars and getting travel arrangements made. In late April, we will be providing you with a link to the implementation tracking form, so you can fill that out for us and tell us how implementation of tools 1 and 2 went and what tools you're interested in for the future. It probably also also in April, late April, we'll be sending you a written document that will do about the data collection procedures. And it's the stuff that you've heard us talk about here today, but it's just in written form and maybe a quick and easy resource for you. It will also identify those links to the online surveys that you'll need. And in late May, we'll provide some additional instructions probably for those folks who are going to collect data using Tool 17 in particular and Tool 8. And in late May, we'll work with you to finalize the selection of your practice-specific tools. And again, in June and July, we will come see you. The main next steps that are coming up, and we can talk about next steps when we get to site visits and talk about things coming up from that point in the project. I want to provide you with some contact information here. So Julie is our manager at the moment, and as I mentioned earlier, she will have probably a co-project manager or someone working closely with her from the American Academy of Family Physicians, hopefully in the next 2 or 3 weeks. So that'll be another contact that we'll make you aware of. Again, I'm Angela Brega. My contact information is here. You're welcome to contact me with questions too. And David West is our principal investigator. You're welcome to contact him about any questions you would particularly like to have him address.